The use of PD-L1 testing in the frontline setting still remains very important for reasons of choice of therapy, because we know that certain patients with high PD-L1 expression will benefit from single-agent pembrolizumab, but also because we need to learn more about what the benefit is in different subsets of patients, depending on their expression. Therefore, I don't see abandonment of the use of PD-L1 expression as a frontline biomarker. It will be supplemented by additional biomarkers such as tumor mutation burden and possibly signatures that predict for outcome, but at this point in time it remains a standard biomarker.
PD-L1 is a crucial predictive biomarker. The results of 024 and now 042 have shown a major survival advantage, first in those who have 50% or higher expression for pembro compared to standard chemo, and now in the 042 trial for those with 1% or higher expression. The key question, however, is whether that advantage is actually realized in the 1 to 49% group. So in 042 is the positive result, this apparent OS benefit, which is roughly about 8 months better, 12 months versus 20 months. Is that driven mostly by the results in the 50% or higher group, or is it shared equally with the 1 to 49% group? For those with no PD-L1 expression, I would not use a checkpoint inhibitor alone, single agent up front. There we have data from 189 that shows, again, a significant survival advantage. That may be the group that will ultimately benefit from some combination immunotherapy. Data from Checkmate 227 has looked at TMB, tumor mutation burden, more than 10 mutations per megabase, and has shown that that group in particular, which is about 40% of our overall population, has a significant PFS benefit versus chemo. I would personally have equipoise in either the 0 population group or the 1 to 49% group, and those with high TMB, comparing the immuno combo, so ipi-nivo, CTLA-4 inhibitor with PD-1 inhibitor, versus the 189 regimen, PEM, carbo, pembro. Again, this is the non-squamous population. I'm not sure what I would do at this point in the squamous population. But that is a critical question I think will ultimately need to be addressed. Right now it's moot. As of early June 2018, the IO combination does not yet have an FDA approval. That may change if the 227 data actually show a survival benefit. I strongly suspect that IO combination will be approved in individuals with high TMB, and then we'll be left with this dilemma: what do we give? That's actually a good dilemma when we have so many different options. My particular bias at this point, given the probable emergence of TMB as a very informative biomarker, is that we should get in the habit of doing next generation sequencing in all of our patients. Certainly in our non-squamous patients, we're already doing that. We need to, beyond EGFR, ALK, and ROS1, we need to look for less common mutations such as BRAF or HER2 or CMET. But TMB can only be generated by NGS. You cannot do this on the basis of immunohistochemical stain as you would with PD-L1. The squamous population, every now and then we find an oncogenic driver. So that reason alone, you can make an argument for doing NGS in that population. And now with the likely emergence of TMB, I would, as I said, get in the habit of doing it. You can make an argument perhaps not to do NGS in the squamous population. I think that's going to change if and when TMB finally does emerge as an arbiter of our therapeutic decisions.